Good morning, and thank you. Well, good afternoon, depending on where you are in the country. And thank you for joining our first educational series webinar. Today's topic is medication adherence and its common barriers. Medication adherence is vital for effective patient care as it directly influences treatment outcomes and overall health. In this presentation, we will cover the importance of medication adherence, the common obstacles patients encounter, practical strategies to overcome these barriers and improve patient compliance. On your screen, you should have the ability to submit any questions that you may have during today's presentation in the chat. These questions will be reviewed and answered at the conclusion of today's webinar. My name is Dana Gress, and I am the Vice President of Clinical Services for Genoa Healthcare. In my role, I am tasked with developing new differentiated clinical programs that drive better outcomes for the consumers that we serve. I'm a pharmacist by trade and have been with Genoa Healthcare for 7 years. I started as a field operator supporting Pennsylvania, New Jersey, West Virginia, and Ohio as a director of operations. I then moved into a divisional vice president role responsible for building out our central fill long-term care and HIV strategy. In 2023, I was asked to develop a clinical services team to redefine our Genoa service offering. Throughout this journey, I've had the extreme pleasure of working with my co-presenter today, Shannon Thompson. Shannon started with Genoa Healthcare 6 years ago as a site manager for one of our pharmacies in the Pennsylvania market. In her first 2 years of employment, she was the recipient of our President Club Award for Rookie of the Year and for Top 10 Site Performances. Shannon then transitioned into our Genoa Clinical Services team as a clinical pharmacist. In this role, Shannon had the opportunity to interact with members across the country and provide longitudinal comprehensive medication management support for consumers living with severe mental illness. She now serves as our program design and implementation specialist and was awarded the 2024 Genoa Outstanding Achievement Award for her contribution to the organization. Thank you so much for your feedback during our 2024 NPS partner surveys. Your comments surrounding a desire for more education provided by Genoa was really the driving focus for the creation of this new educational series. We're excited to offer these webinars and we'll be recording them and placing them on our Genoa Healthcare website. This will allow all of you to review previous recorded sessions as well as easily share the content with anyone in your organization. And without further ado, I am going to turn the meeting over to Shannon.
All right. Well, thank you for the introduction, Dana. Hi, everybody. My name is Shannon Thompson. As Dana mentioned, I'm a pharmacist by trade, and I currently serve as the Program Design and Implementation Specialist here at Genoa Healthcare. I am pleased to kick off our first monthly educational series webinar today, so we'll go ahead and get started. As Dana mentioned, today we will delve into the critical topic of medication adherence and the common barriers that come with it. The objectives of today's presentation include defining and describing non-adherence, understanding common adherence measurements, including PDC, which is proportion of days covered, and MPR, which is medication possession ratio. We will describe barriers to medication adherence, identify behavioral health disease states with the highest adherence risk. We will list common adverse reactions to behavioral health medications, and finally understand the role of the pharmacy as part of the care team. By understanding and addressing these challenges, we aim to improve patient compliance, enhance therapeutic effectiveness, and lower healthcare costs. Mental illness affects millions of individuals in the U.S., significantly impacting their daily lives and overall well-being. Medication adherence is a critical factor in managing these conditions effectively. 1 in 4 people have a mental illness, and 60 million individuals have a serious mental illness. 45 million people have a substance use disorder. On average, individuals living with mental illness use 48 prescriptions per year. $320 billion is spent on medical care with a shift toward outpatient recovery. 65 million adults use a medication for mental illness. Understanding the prevalence of mental illness and the challenges associated with medication adherence is essential for improving outcomes and reducing healthcare costs. This next section offers an overview on adherence and non-adherence. The definition of adherence and non-adherence is essentially the same. Really, the only difference is the lens in which you view it from. The definition of adherence is the degree to which a person's behavior aligns with the agreed recommendations from a healthcare provider. Adherence is important because adherence to therapies is the primary determinant of treatment success. We can personalize the approach to improving adherence by identifying specific barriers for each patient and adopting suitable techniques to overcome medication adherence barriers. Adherence rates are typically higher among patients with acute conditions compared to those with chronic conditions. Non-adherence is defined as the degree to which a person's behavior does not align with the agreed recommendations from a healthcare provider. Half of individuals who are sick and suffering enough to be prescribed medication are not getting it, and this is resulting in more emergency room visits, hospital admissions, and disability. Not taking prescription medications is common, frequently undiagnosed, unaddressed, and is a major cause for poor treatment outcomes. So while non-adherence can be an issue in any patient group, the problem is inflated for those living with a mental illness. They have 3 times the number of office visits, 10% higher hospitalization rate, and they cost payers $185 billion per year. A prospective study of risk factors for non-adherence with antipsychotic medication in the treatment of schizophrenia shows the different relationship between adherence and psychiatric admissions. Closing the gap can lead to meaningful cost savings. For reference, on average, a retail pharmacy has a medication possession ratio, or MPR, of 50%, which according to this study would equate to an 18.5% rehospitalization rate. On average, Genoa's MPR is greater than 90%. And so in keeping with this study above, would equate to a rehospitalization rate of about 8.3%. This improvement correlates to $1.6 million per 1,000 consumers served at a Genoa pharmacy versus a retail pharmacy. The consequences go far beyond medical and inpatient costs. There are 3 types of non-adherence. Primary non-adherence occurs when providers write a prescription, but it's never filled. This can also be referred to as non-fulfillment non-adherence. Non-persistence non-adherence is when patients decide to stop taking a medication after starting it without being advised by a healthcare professional to do so. This type of non-adherence is rarely intentional and occurs when patients and providers miscommunicate. Non-confirming non-adherence is when medications are not taken as prescribed. Examples of this type of adherence would be skipping doses, taking medications at incorrect times or at incorrect doses, and taking more than prescribed. Non-adherence can lead to several negative consequences, including waste management in the form of insufficient use of medications and resources leading to waste, disease progression or worsening of the disease, reduced functional abilities such as decreased ability to perform daily activities, lower quality of life or an overall decline in well-being, increased use of medication resources resulting in a higher demand for medical treatments and interventions, serious health consequences leading to the potential for severe health issues, and emergency hospitalization or an increased risk of urgent medical care and hospital admissions. This study displayed on your screen here was carried out to evaluate factors resulting in medication non-adherence within 6 months before admission to the psychiatric service of a hospital. 203 patients admitted to the psychiatry service of the medical facility were included in this study. Sociodemographic parameters and clinical findings of medication non-adherence were examined. Patients were classified into 4 different groups according to their diagnosis: bipolar disorder, schizophrenia and schizoaffective disorder, depression, and then others. The ratio of medication non-adherence was higher in the bipolar disorder group when compared to the groups with schizophrenia and schizoaffective disorder, depression, and other disorders. However, the ratio of medication non-adherence was similar in schizophrenia and schizoaffective disorder, depression, and the other disorders group. The leading factors for medication non-adherence were not willing to use medication, not accepting of the disease, and being disturbed by side effects in the bipolar disorder group, not accepting the disease in the schizophrenia and schizoaffective disorder group, feeling well in the depression group, and being disturbed by side effects in the other diseases group. Medication non-adherence is an important problem in psychiatric patients and should be dealt with by taking into account the diagnosis, attendance to follow-up appointments, and the patient's attitude. Ensuring regular attendance to follow-up appointments, adjusting the management plan according to the diagnosis, and improving their thoughts about resistance to medication can be beneficial in terms of medication adherence. There are several factors that contribute to non-adherence, including poor communication, not being convinced of need for treatment, fear of adverse effects, complex regimens and cost, chronic disease states, health literacy, and cultural demographics. It's been reported that 40 to 60% of patients cannot correctly report what physicians expected of them 10 to 80 minutes after provided with the information. And additionally, greater than 60% of patients interviewed immediately after visiting their provider misunderstood the directions regarding their prescribed medications. Barriers to medication adherence include lack of social support, such as limited or inadequate patient information, weak professional or family support, low education, homelessness, or weak community functioning. Health system related factors such as inadequate availability or unavailability of psychotropic drug supplies in health facilities, lack of free access to medication, and health professional shortages, as well as lack of insight about illness and medication, such as misunderstanding treatment consequences and lack of awareness of illness or mental disorder. The various methods to improve adherence include simplify medication taking, explaining key information when prescribing and dispensing a medication, informing of common side effects, using medication improving aids such as a pill box or unit dose packaging, identifying patient-specific barriers related to adherence, and medication synchronization. The pharmacist on your care team uses many strategies mentioned previously to help improve medication adherence for patients. Our pharmacists provide patient education to help them take medications as prescribed, as well as educate on side effects and how to manage them. Medication counseling to address concerns and questions that patients have about their medications. Simplifying regimens by working with providers to reduce the number of doses per day or potentially switch to a combination medication as appropriate. Medication synchronization, where the pharmacy can coordinate refill schedules so that all medications are filled at the same time. Reminder systems, including Genoa Care packaging, which is a multi-dose packaging solution that provides medication to patients in an all-inclusive blister pack, as well as regular follow-up and reminder check-ins. And finally, building relationships with our patients that encourages them to be open about the challenges that they're facing. All right, we've come to our first poll question to test your knowledge. So earlier we learned that non-adherence can be an issue in any patient group. The problem is inflated for those living with a mental illness. Would you expect to see A, 3 times the number of office visits, B, 35% higher hospitalizations, or C, a cost to payers of $18 billion per year? And let's go ahead and use the chat to submit your answer. And I'll give everybody a few seconds to do so. All right, we've got an A. Who else? We've got a B. Okay. A few more B's. All right. All right. Any more last minutes? A bunch of B's. Okay. All right. Very good. Well, the correct answer is actually A. Dana got it right. It is 3 times the number of office visits. Option B is incorrect. We actually expect to see about 10% higher hospitalizations. And option C is also incorrect, as we would actually expect to see a cost to payers of about $185 billion per year. All right, and then here's our next poll question. Earlier, we learned the different types of non-adherence. What type of non-adherence is described below? So this would be if the medications are not taken as prescribed and doses of medications are skipped. Go ahead and use the chat to put in which type of non-adherence you think is described here. All right, we've got C, okay. Another C, awesome. Another C. Very nice. All right, the popular choice. Well, you guys are on it. The correct answer is C, non-confirming non-adherence. So if we remember from earlier, primary non-adherence is when a prescription is written and never filled. And then non-persistence non-adherence is when patients stop taking a medication without the consent from their provider. Great job. All right, moving along to our next section. This reviews common adherence measurements and highlights the similarities and differences between them. Medication possession ratio, or MPR, is a measure used to assess medication adherence. The formula for this includes the sum of days' supply of medication dispensed divided by the number of days in the observation period. An MPR of 0 means that the patient is completely non-adherent, whereas an MPR of 100 means the patient is perfectly adherent. Limitations to the MPR include an overestimation of adherence. So, for example, if a patient refills their medication early, the MPR calculation includes overlapping days supply, which will inflate the adherence rate. Another limitation is lack of usage data, as MPR is based on refill records and does not account for whether the patient actually takes the medication as prescribed. The proportion of days covered, or PDC, is used to estimate adherence by looking at the proportion of days in which a person has access to the medication over a given period of time. PDC is calculated by taking the total number of days covered by refills in a time period divided by the number of days between the first fill and the end of a time period. So just like MPR, a PDC of 0 means no adherence, and a PDC of 100 means perfect adherence. The PDC considers whether a patient has finished their current fill of medication before starting the next refill. Limitations of this calculation include lack of usage data, as well as the calculation being a little bit more complex as compared with MPR. While both of these measurements can be used to measure adherence, they do have differences. The MPR calculates the sum of days supply for all fills divided by the number of days in a time period, whereas PDC considers days that are covered based off of fill patterns. For example, take a medication that was filled for the first time for a 30-day supply. The first refill of this medication is 3 days late, and the second refill is 7 days early. The MPR reflects this as a value greater than 100%, which overestimates the adherence to the medication. Using PDC avoids this overestimation issue as seen with MPR, reflecting a more accurate value of 96%. MPR can overestimate adherence. In this example, the MPR calculation resulted in 104%, which is not possible in reality. The overestimation occurred because NPR sums the total day supply without accounting for the timing of refills, leading to inflated adherence rates when the refills are early. The PDC provides a more accurate measure of adherence. So in this example, 96% better reflects the actual medication coverage. PDC considers the specific days covered based on fill patterns, making it less prone to overestimation compared to NPR. Part of the strength of the Genoa high-touch model is our ability to proactively manage patients' medications, in that we reach out at least 14 days before the patient would be out of medication to ensure that there's no gaps in care. This can at times result in a refill and a patient receiving the medication prior to fully exhausting the previous month's dispense. Therefore, the timing of refills significantly impacts the adherence calculations. Early refills can inflate NPR while PDC adjusts for the actual days covered, providing a more realistic adherence rate. So overall, PDC is a more reliable metric for measuring medication adherence as it accounts for the actual fill patterns and avoids the overestimation issues seen with NPR. So with all of that said, that brings us to our next Check Your Knowledge poll question. So which adherence measurement can lead to an overestimation of patient adherence? Would this be A, NPR, B, PDC, or C, neither of these? Okay, A's are rolling in. Oh, wow, that's popular. Okay, lots of A's. Anyone else? Okay, all right. Well, you guys nailed it. Correct answer is A, NPR. NPR can overestimate adherence, again, because NPR sums the total day supply without accounting for the timing of refills. This can lead to that inflated adherence rate when refills are done early. Okay, on to our next section. So this section reviews drug classes with the highest adherence risk specific to behavioral health medications, as well as the factors that cause these risks. So we've reviewed throughout the presentation that non-adherence can significantly worsen a patient's condition and reduce effectiveness of treatment. As a reminder, the common barriers in the behavioral health population include forgetting to take medication, only taking medication when sick, stopping the medication when feeling better, side effects, cost, lack of social support, fear, and mistrust. Antidepressants have non-adherence rates as high as 97%. Non-adherence to this class of medications has been linked to suicide attempts. Antipsychotics have non-adherence rates as high as 60%, and non-adherence to this drug class has also been linked to suicide attempts as well as premature mortality. Recent studies indicate that non-adherence to antipsychotics leads to an average reduction in life expectancy of 28 years. Mood stabilizers have non-adherence rates as high as 56%, and non-adherence to this drug class has been linked to hospital admissions. Listed on this slide are the common side effects of the previously mentioned drug classes. So antidepressants, we commonly see dysphoric mood, agitation, headache, dizziness, and decreased sexual interest. For antipsychotics, oftentimes we see agitation, insomnia, rebound psychosis, dyskinesia, and weight gain. And for mood stabilizers, oftentimes we see dizziness, fatigue, tiredness, sedation, lethargy, restlessness, and extrapyramidal symptoms. It's important for patients to understand side effects of their medications so that they know what they can expect and how to best manage any side effects that they may experience. Continued communication and collaboration across the integrated care team can drive better education around the expectations of therapy and how to manage through short-term side effects in drugs with long-term build to efficacy. All right, so we have reached the final section of today's presentation, and that is having a pharmacist on your care team. So now that we have reviewed what adherence and non-adherence mean, learned the difference between adherence measurements, and identified that medications used in the behavioral health space are associated with the highest risk for non-adherence. We now want to talk about the importance of having a pharmacist on your care team and how to best utilize the pharmacist to drive better outcomes for our patients. Our Genoa pharmacies partner with organizations like yours that serve those who need it most to improve outcomes and make life easier for those that you serve. Our model of care is truly focused at meeting the patient where they are in their journey. To ensure that they have access to their medication needs at all times and can manage the complexity of their disease state, we offer free medication packaging, such as care packaging, which formerly was referred to as dispill packaging, as well as strip packaging, bubble packs, and other options. We also help address transportation barriers by offering mailing and delivery services when needed. Our pharmacists are trained in mental health first aid and can help to identify signs of a mental health crisis. Our pharmacists build trust with patients through effective and frequent communication. They help to navigate insurance challenges, including prior authorizations, help to get access to patient assistance programs and copay cards, and work with your providers to find cost-effective alternatives if copays are too expensive. We help to prevent drug errors by screening for drug interactions and performing medication reconciliation to ensure your patients are getting the most out of their medications. And we collaborate with your care team for comprehensive and coordinated care, including medication administration as needed. We also offer clinical wraparound services with enhanced education services for a wide variety of specialty behavioral medications. These services are in addition to everything that you see on your screen and are designed to drive better education around expectations of therapy and how to manage short-term side effects in drugs with long-term build to efficacy. We encourage our center partner staff to get to know our pharmacists and the pharmacy team so that we can work together to give your patients the best care possible. All right, and here's our next poll question. How can pharmacists as part of your care team affect patient care? We have A, prevent drug errors by detecting drug interactions. B, building trust with patients and providers through great communication. C, navigate prior authorizations and assist with financial assistance. Or D, all of the above. We've already got D as an answer before I finished reading. You guys are quick. All right, answers are coming in. Lots of D's. I teed that one for you guys, didn't I? No, that's awesome. Correct answer, of course, is D. Pharmacists can affect patient care by performing all of these actions. Great job. All right, and before we end today, we would like to get your ideas for future education series. So while we have a lot of content that's already planned, we're certainly always open to what's going to be most impactful to all of you. So as we think about a few broad topics, this can be things like clinical content, including disease state education, diagnostic criteria, and traditional and new treatment options, dosing or prescribing information, or anything else that you can think of. So please use the chat to let us know what you would like to see covered in future webinars, and please don't be afraid to be specific in your response. If there's something you really want to see or something, that's really piqued your interest, please feel free to put that in the chat and we will be happy to take that into consideration. Right. Well, I didn't want to put anybody on the spot, so we won't do that, but we can leave the chat open even after the conclusion. That way, if something comes to mind or you want to think on it a little bit, you can feel free to put your response in the chat at that time as well. Very good. Okay, here are the references that we used for today's presentation. As we prepared for this educational series, we relied heavily on a series of studies and articles to help inform. Okay. Awesome. Thank you for that, Diana. New dosing changes. Okay, very good. Appreciate the feedback. But that sounds good. Like I said, we'll leave the chat open, so feel free to enter things even after today's webinar concludes. But this does conclude today's presentation on medication adherence and its common barriers. Please note that the next upcoming webinar presented by Genoa Healthcare will take place on Tuesday, April 8th at 12 noon Central. This presentation will address long-acting injectables in practice and what providers need to know. The link to register is on the screen, but I'm going to go ahead and put that in the chat for you. That way you can interact with it and send it to anyone else that might want that. And then in addition to the clinical webinar series coming out on April 8th, all of the clinical education series webinar recordings are going to be housed on Genoa's website. So today's posting, or today's recording rather, will be posted on the web page at some point in the middle of next week. I will make sure that I put this link in the chat as well. That way you can use that for yourself, share it with any external clients or co-located center staff. I will put that link on here as well. This page will allow you to access previous educational series webinars, so all of them will be on this page as a playlist. And there will also be the link on the same page to register for future upcoming presentations. So I'll make sure that you get the links in the chat after this concludes. And also, if you have any additional questions, please submit them in the chat and I will be happy to answer any of them. But without further ado, that concludes today's webinar. So I appreciate all of you for attending. Thank you so much. I hope you have a great rest of your day and a fantastic weekend.